Yeah, good evening to all of you. On behalf of Torrent Pharma, I welcome you all to this live video conference on the occasion of World Osteoporosis Day. At Torrent, it is our endeavor to develop and manufacture world-class quality products at affordable prices and also provide a platform to share knowledge. With the support of eminent fraternity in orthopedics, gynecology, and endocrinology, this live video conference has been conceptualized as an academic forum where the mentors can share their academic brilliance and practical experience. I must admit that the response we have received is appreciable. I thank all of you for your support and once again welcome all. I would also like to thank the esteemed speakers Dr. Sarita Balerao, Dr. Amay Joshi, and Dr. Prakash Kotwal. And today our esteemed moderator Dr. Ved Prakash for sparing their valuable time. Now I will request Dr. Ved Prakash to take charge of this conference. So before handing over the session to Dr. Ved Prakash, let me have the opportunity to introduce to all of you a senior person in orthopedics. He is having an experience of 65 years of rich experience. Decade of experience is National Health Service of UK in various aspects of surgery, such as emergency, trauma care, thoracic and cardiovascular surgery, and abdominal surgery. His fields of interest mainly are hip surgery, spine surgery, and trauma care. However, being a general orthopedic surgeon, he does almost all orthopedics work, including pediatric orthopedics and congenital deformities, etc. Speaker at many national and international seminars and conferences, presented many papers, around 40 publications on his name. He is the president Andhra Pradesh State Chapter of Indian Orthopedic Association from 1988 to 89. He was a member of Executive Committee of Indian Orthopedics Association 1985 to 90. He is the president Twin Cities Orthopedic Society 1991. Honorary orthopedic surgeon, St. Teresa's Hospital, Hyderabad from 1970 to 94. And is a member of Rotary Club of Hyderabad from 1969 to 2007. Now, I request Dr. Ved Prakash to take charge of this conference.
Right. So please put on the, yes. I'm grateful to Torrent, particularly Mr. Krishna Reddy, who has requested me to moderate today's live session, seminar on osteoporosis, which is a very important subject, even though it's been discussed for last 20, 30 years, but it still carries tremendous amount of interest, and it should, because we have not been able to conquer anything in the medical field, including osteoporosis. So always this knowledge, medical knowledge, will always be incomplete. In fact, practice medicine is a question of art. So there is no end to perfection of art. So remember that few words before I introduce the great speaker, Dr. Sarita Balerao, who is Vice President of MOGS 2020 to 21, and is a Breach Candy Hospital consultant, Reliance Hospital, Sai Free, and Bhatia and Wadia Maternity Hospitals. And she has got rich experience, 26 years, and Vice President, Mumbai, of Obstetrics and Gynecological Society, MOGS, Chairman of AICC, RCOG, West Zone 2020 to 22, Member of Governing Council, ICOG, and 2018 to 20, Joint Secretaries, FOGSI 2017, Immediate Past President, AMWI Mumbai Branch, Past Chapter Secretary, IMS Mumbai Chapter, and Quiz Committee Chairman, FOGSI 2009 and 11. So this is Sarita Bhalerao. So, should I speak before or about the subject given, or Krishna Reddy?
Sir, you speak first. You speak
You
first.
can give
Right,
few words, sir.
right,
Then
right, right.
you can hand over to Dr. Sarita Bhalerao.
The subject given to me is prevalence and overview of osteoporosis. Friends, some of it I'm speaking from memory, some notes I have done. So please give me time of at least 10 minutes to finish it. The prevalence is increasing day by day all over the world. Almost 20 million people all over the world, and presently possibly about 46 million of people are suffering in this country of osteoporosis, particularly both male and female, but females 1 in 3, and males, maybe the various statistics include 1 in 5 to 1 in 8, but depends upon the area in which, because we have not done a whole country survey, so it is difficult to really push upon our statistics. Even then, Vidarbha, they have done a survey, particularly Sanjeev Chaudhary and his colleagues, and they have found that the Vidarbha, there is the females over 45 have 43.33% of the population of women is suffering with this osteoporosis. Highest is in the female executives. Are you hearing, all of you? Are you hearing, all of you?
Yes, yes, sir, we can hear you.
Sorry. Now, this was published in International Journal of Orthopedic Sciences in 2015. Then Indian menopausal women, Indian men particularly, with a low T-score are likely to suffer with osteoporosis. And I think this should be always known to the orthopedic surgeons and whoever, the endocrinologists who are dealing with this osteoporosis business. Early menopause is main cause. Low calcium intake is a big problem in our country. Increased longevity and illiteracy, which is very common. Anuradha Khadilkar and Rubina Mandlik published online 2019 their statistics. They are saying that 230 million are expected to be above the age of 50 years soon. So that was done in 2015, but I'm sure it's much more now. And they were expecting 46 million of people suffering with osteoporosis. Now from 36, which was in 2013. Now, the main cause for this is ignorance, changed lifestyle. We are unable to go out in the sun. Most of the people are using digital media and they have got no exercise. Most of them do not do yoga exercises, any exercise, walking. So all that lifestyle also has changed. Calcium and vitamin D deficiency is common in our country, very common. And not only in our country, but also UK and US also. And of course, this percentage is different. The main treatment which has been suggested is calcium, vitamin D, bisphosphonates as the first line drugs. Other line of drugs are hormonal therapy, which is a bit dangerous to continue after 1 year or 2 years. Then estrogen agonists, calcitonin, nasal spray is being used. Parathyroid hormone, teriparatide altered, is being used. But the treatment depends mainly in our country upon the affordability of the patient, which is very important. And doctors' hands are tied. The other factors are racial. Indian women and Caucasian women, white women are the sufferers. Africa, bones density is more. And then the results, what it does is to decrease the quality of life and causes disability. You get pathological fractures, which may be the first sign to appear when the patient presents to the surgeon or endocrinologist. And it is very important that we have an increased awareness amongst doctors. Facilities to increase awareness in normal populace depends upon the private doctors, their own physicians, general practitioners. Bone is a living tissue, and 99% of the calcium is in the bones stored, and 1% possibly is in the blood in the ionic form. Bone is a plastic structure, not a hard structure, because of the presence of collagen in it. Collagen framework and the calcium phosphate, which is deposited in it, makes it strong. But there is a continuous exchange which takes place between the removal of bone and the new formation of bone. And osteoporosis is the result of less formation and increased removal. So this increased removal takes place after the age of 45, mainly women who are suffering with menopause. And I think Dr. Sarita is going to talk about that. And we have, in addition to this, calcium deficiency in many families which do not have a proper diet. Nutritional problems are there. Availability of enough food is not there. Correct food is not there. They eat whatever they like. There is no special, instructions to them, particularly in the rural areas. Smoking and alcohol in the modern lifestyle is a great cause for having weak bones. Then education of the public in this field has got to be there. And then they must be given the right food, vegetables, green vegetables, whatever it is. Then many other things are there which cause osteoporosis. There are in the lifestyle problem, because we don't go out in the sun, vitamin D production is very little. So walking is important. Stretching of joints is important. Sitting, only taking food is not good. There are many other causes which our experts are going to highlight. Now, parathyroid hormone or bisphosphonates. Bisphosphonates should be the first line. And if it doesn't work, you have got to use teriparatide and parathyroid hormone for treatment. Then it is very important that in elderly, we take care about their lifestyle. Fall prevention is very important. The early elderly people who are in the Western world are alone. And in our country, they are neglected most of the time, even though they live in a joint family. They need to be looked after well, and the awareness of osteoporosis and fracture has got to be there in the public domain. Then the requirement of calcium differs with ages, different age from childhood till the adulthood. And in the end, I would like to say that osteoporosis cannot be neglected. It is the fourth lifestyle problem which the orthopedic surgeon tackles mostly, and this comes within the 60% of the outpatient, in which I have got 3 more diseases, and that is cervical spondylosis, osteoarthritis of knee, and the low back pain because of this. And being a silent disease, and the first ever, sometimes the symptom is pain at the fracture site. So it has got to be monitored even before the women in postmenopausal period become osteoporotic. So it's highly important that the gynecologist, it is a duty of the gynecologist to warn the women that they should start calcium, but the calcium should be taken right after 30 years when you reach the peak bone mass. So with that few words, I'm so grateful to Torrent Pharma to allow me to moderate this session. Thank you. Now, Dr. Kotwal's, I have not read. Are you going to talk first, Dr. Kotwal?
No, it's Dr. Bhalerao, I suppose.
Yes, yes. So I have introduced Dr. Bhalerao, and now I would like Sarita Bhalerao to get on with this. Before each member, he will be introduced before their talk. So I'm introducing Sarita, who has got a rich experience, 26 years, and I have already read about her biodata. I would request Sarita to start speaking now. Thank you.
Thank you, sir. Thank you, Dr. Prakash, for that kind introduction, and congratulations to Torrent for taking this wonderful initiative. Today is World Osteoporosis Day, so I think that it's really a wonderful move to have this program today. So I'm a gynecologist, as sir said, and based in Mumbai, and I'm going to focus on the problem of postmenopausal osteoporosis. Can I share the screen?
Yes, sure.
Yeah. Okay, I'm just going to do a slideshow from the beginning. Can you see my screen?
Yes, yes, of course.
Yes, and I'm audible. So I'm going to talk to you, and women go through a phase of life, many phases of life. Now life expectancy has gone up, so that women are spending almost 1/3 of their life in menopause. And one of the serious problems leading to morbidity and even mortality of women in menopause is the problem of osteoporosis. Now, menopause is something which is very natural and unfortunately negatively impacts a woman's quality of life. And today our focus is that women should be strong at 60, independent at 80, and we really want our women to continue to be very productive right till they can. Now, menopause leads to a decrease in the level of the hormone estrogen. And this estrogen hormone has many target tissues all over the body. Hormone deficiency, estrogen deficiency, leads to many changes, which you can see on the left-hand side, and I'm going to show it to you. And vasomotor symptoms, hot flashes and night sweats, are the most common things that the patient presents with. Long-term complications include cardiovascular disease like heart attacks, strokes, etc. Osteoporosis is another problem that we often see as women enter the 7th and the 8th decades of life. Mood changes, amenorrhea are common problems, and the genitourinary syndrome of menopause, leading to recurrent urinary tract infections, dyspareunia, is also a problem. So there are also some problems with hormone excess, and breast and uterine cancer is an area which is of concern, and that is why we cannot give hormone replacement therapy to all our women. We have to give it under supervision for very, very clear conditions. So let's look at the dynamics of perimenopause. A woman is born with a certain number of eggs in the ovaries. These eggs from birth onwards, these go through a phase of depletion. After 40, the eggs go down drastically, and by the time a woman reaches the age of 50, the ovarian reserve is depleted. Around the 50 is the average age of the final menopause menstrual period. And as the estrogen and the progesterone levels go down, there is a rise in the level of follicle stimulating hormone, which is one of the tests that we do to diagnose menopause. And this also has effects. FSH also has effects on the bone, just like the hormone estradiol has. So natural menopause is a retrospective diagnosis. We define it as a cessation of menses for 12 consecutive months without any other medical cause. The median age of natural menopause is approximately 51 years, but it is variable. It could be 45 years to 55 years. In our country, sometimes it is earlier at 45, 46, 47 years. And the root cause is the depletion in the ovaries. And it marks the end of the reproductive life. Now, as I said earlier, that menopause has an impact on many different systems. On vasomotor symptoms, because estrogen plays a role in thermoregulation by modulating the level of neurotransmitters. So hot flashes and night sweats are often the commonest symptoms that patients present with in the early perimenopausal period. Then they present with urogenital symptoms, where the vagina loses its elasticity. There's a change in vaginal pH leading to urinary tract infections, vaginal discomfort, burning, and difficulty in intercourse. Long-term effects include effects on the skeletal system like osteoporosis. Osteoporosis is decrease in the mass of the bone mass, as well as distortion of the microarchitecture of the bone, making the bone weak, making the bone fragile, and making the bone more prone to fractures. Also, there is a change in the cardiovascular system, and it makes the woman more prone to insulin resistance, change in the distribution of body fat, and eventually an increased incidence of ischemic heart and of stroke. Now, bone loss, in a woman, the peak bone mass is achieved at the age of 35 years. And after that, there is a slow reduction in the bone mass. But after menopause, in the first 5 years of menopause, there is a rapid loss in bone mass. And that bone mass in just the first few years of onset of menopause may be as high as 20%. After that, the bone loss continues, but at a lower rate. So it is this phase that is very, very important. And as Dr. Ved Prakash sir said, osteoporosis is a huge problem. It's a huge public health problem, and women are affected more than men. 1 out of 3 females in India suffers from osteoporosis, and hip fractures, vertebral fractures are an enormous cause of morbidity. The secondary complications arising out of hip fractures are an important cause of even mortality. So I think that this is really an area where we need to have focus our public health efforts. Currently, it is estimated that over 200 million people worldwide suffer from osteoporosis. In India, the prevalence of osteoporosis in postmenopausal women in various studies is very high, between 25 to 62%. And recently, last year, we had wonderful data which came from CMC Vellore, Dr. Paul, and they really showed how, osteopenia and osteoporosis is a big problem. Aging of populations worldwide is responsible for a major increase in the incidence of osteoporosis. As our population ages, we're going to see this problem more and more. I'm not going to go into all these studies, but just to tell you that many studies have been done, and I just want you to focus on they have all evaluated bone mineral density of women over 40 years, for 30 to 60 years. And you can see that the incidence of osteopenia and osteoporosis is so high, and almost 1 out of 3 women is having osteoporosis, and 1 out of 5 or 1 out of 6 is having osteopenia. So when we look at the prevalence of osteoporosis at the lumbar spine in women according to the menopausal status versus men, you can see that in premenopausal women we have here, whereas postmenopausal women we have a bigger incidence of osteopenia and of osteoporosis. So that is just to tell us that menopause is a very, very important point in this thing. Prevalence of osteoporosis at the femoral neck also is showing us that the incidence of osteopenia and osteoporosis is much higher in women compared to men after menopause. Now, in clinical practice, patients may present with very vague symptoms. They may just present with backache, they may present with joint pains, they may present with body pain. So clinical diagnosis of osteoporosis may be difficult in the early stages. So we need to really screen our pregnant women, and what our guidelines say is that pregnant menopausal women are over the age of 50 or after 5 years of menopause must have a bone mineral density to assess their incidence of osteoporosis. Why does estrogen cause this bone loss? And this is because estrogen is one of the key factors in the balance between osteoblasts and osteoclasts. It's the osteoblasts which form the bone, it's the osteoclasts which eat up the bone or resorb the bone. And estrogen deficiency is increasing osteoclasts, which are then eating up the bone. And the net effect is loss of bone, destruction of the local architecture of the bone. And here on the left hand side you can see a normal bone and a bone with osteoporosis, showing this effect of estrogen deficiency. Now, calcium and vitamin D deficiency also, as Sir said, plays a very important role. Dietary calcium, dietary vitamin D intake is very important, and vitamin D increases the absorption of calcium and therefore improves bone turnover and improves bone formation. So this is one of the important correctable factors. So many of our women are vitamin D deficient. They have poor calcium because their dietary intake of calcium is poor. And this is a very, very correctable thing that we can do. And we can maybe not prevent the bone loss completely, but slow the rate of bone loss. When you look at in the incidence of osteoporotic fractures in women, you can see that the most important thing is the vertebral fractures, leading to a loss in height, collapse of the spine, the hip fractures, which are disastrous because they, take away the woman's independence, her mobility, lead to secondary problems, and also we have the wrist fractures. And as our population ages, as the woman goes into the 70s and the 80s, the problem of vertebral and hip fractures becomes a really significant problem. Osteoporosis is often known as a silent disease, because sometimes it doesn't present until the first fracture. Until the fracture occurs, it doesn't present. So often it is silent, insidious, progressive in nature, associated with significant morbidity. And the idea is to now predict future spine and hip fractures so that we can reduce the risk of death. So what are the risk factors in postmenopausal women? Age greater than 65 years, family history of severe osteoporosis, premenopausal amenorrhea for a period greater than 6 months, inadequate calcium intake, those who are smokers, and those who have intake of higher alcohol. These also added to the other factors, which are the general factors, those who have been on glucocorticoids or immune suppressive, those are other things. Coming to the pathophysiology of estrogen deficiency and osteoporosis, I'd like to just make it very simple to say that estrogen deficiency acts through these mediators, which are interleukins, tumor necrosis factors, etc., and basically activate osteoclast mediated bone loss. and decreased parathormone secretion, leading to decreased production of vitamin D, decreased intestinal calcium absorption, and finally leading to bone loss. So estrogen deficiency acts in different ways. We also know now that FSH itself, as it rises, has an effect on the bone and the effect on these mediators, and both the effects are leading to bone loss. So here we are looking at the osteoblast, which forms the bone, and we're looking at the osteoclasts, which eat up the bone, and this balance is maintained very, very carefully by estrogens with its effects on apoptosis. The word apoptosis means cell death, and through other things such as cytokines, interleukins, etc. Now, this is a very interesting concept of increased RA-NKL levels, which lead to osteoclast activation and increased bone reception. And RA-NK is receptor activator of nuclear factor kappa B. It's all very, sort of theoretical and academic, but these are factors now that we know work on the osteoclasts, and that is how estrogen deficiency manifests. So postmenopausal osteoporosis, with years indicating the time of discovery of new pathogenic mechanisms. Through the years of the last 20, 30 years, many things have learned. We knew initially that it was estrogen that caused deficiency, but how we did not know. And now we know that it is through all these different things. So let's take a look at some clinically oriented things, and that is how do we diagnose bone mass and how do we manage our patients. So the gold standard is the DEXA, the DEXA scan, and for bone densitometry, and that is a very, very good thing. Though it is a little expensive, it is very good. So we have also other, ultrasound for heel and things, which are screening methods, but the important one is the bone densitometry with DEXA. And to make things very simple, there is a T-score and a Z-score, and the T-score will tell you as compared to what is the bone densitometry, whether it is osteopenia or whether it is osteoporosis. There's also now a lot of web-based new tools called FRAX, which are fracture assessment, which use multiple modalities to assess the patient's risk of having a fracture, from her age to her menopausal status, to her to her BMI, to her family history, etc. And these tools are available through the net, which you can use to assess the patient's risk of fracture. So our focus now in clinical practice is to identify high-risk patients. We want to identify them and prevent the fracture before they reach our orthopedic surgeons. We try to prevent fractures. So primary goal is fracture prevention. Therefore, we have to select patients based on the risk of fracture. Pharmacological therapy for patients with osteopenia and with osteoporosis or with a history of hip or spine fractures. And we can use the FRAX tool for a quantitative risk assessment to communicate the risk to patients, and it may help us to better select patients for treatment modalities. Simple treatment is lifestyle modification. Dietary calcium helps in maintaining the strength and structure of bones. Women who have good calcium in their diet, that helps them. Women who are physically active, exercise, walking, weight-bearing exercise, those who do yoga, will have better bone mass and better strength. And those who are athletic from their childhood, young women, they're going to have a better peak bone mass, and it's going to help them in their 70s and 80s. Reduced physical activity is a major risk factor for the development of osteoporosis and fractures, and sedentary lifestyle is a problem. Also, other things like elderly people are more prone to fall because of poor eyesight, loss of coordination, and development of neuropathy, and we have to protect them against this. So when we look at menopausal osteoporosis and pharmacological therapy, our first line is to give calcium and vitamin D3 with lifestyle changes, then to go on to bisphosphonates. Menopause hormone therapy, again, is a controversial area. We are allowed to give according to the international menopause guidelines, to give short-term hormone therapy for symptomatic relief, which will also help the bone. but to give only for bone strength is not recommended, simply because long-term hormone therapy has complications of breast cancer and endometrial cancer, etc. There are other medications such as selective estrogen receptor modulators like SERMs, like raloxifene, and there are other medications like parathyroid hormone, teriparatide, calcitonin, and denosumab. Now, we have International Menopause Society guidelines, and these IMS guidelines for postmenopausal osteoporosis are very, very clear. And they say that the choice of pharmacological therapy should be based on the balance of effectiveness, risk, and cost. And the treatment may be started in patients who have got a fragility factor or a T-score less than or equal to minus 2.5, or a T-score of between -1 and 2.5 with additional risk factors. Calcium supplementation should be restricted to bridge the shortfall between dietary intake and daily required intake. But as we know that many of our women their diet lacks calcium, and therefore we should give them calcium. And our choice of therapy is, as I said before. So calcium and vitamin D are considered as first-line treatments. Vitamin D supplementation in the form of cholecalciferol is one of the earliest treatment for osteoporosis. Vitamin D deficiency is prevalent in 70% of the general population of our country. And this photograph on the right-hand side shows the web-based FRAX tool, which has all the different factors which you can actually use in practice and use for your patients. Now, calcitriol is a vitamin D3 analog. So vitamin D3 has a beneficial effect on fracture risk through increases in BMD and improvement in muscle strength. But to become physiologically active, native vitamin D, D2 or D3, undergoes successive hydroxylations in the liver and the kidney to produce 25-hydroxycholecalciferol or calcitriol, which is 1,25-dihydroxycholesterol. So calcitriol is the active form of vitamin D and is believed to mediate most of the biological actions of vitamin D. A potential advantage of triol over vitamin D3 is that it avoids the effect of aggregate age-related declines in hepatic and renal function. Now, when we look at our clinical practice guidelines that we have, vitamin D deficiency has been considered as a national nutritional deficiency pandemic. According to clinical practice guideline, maintenance therapy was 2,000 international units per day for postmenopausal women. So since dietary sources are limited, the government of India has permitted fortification of food, which will enable our population to get an enhanced intake of vitamin D. Vitamin D is basically through sunlight, but there are so many factors. People have to be in the sun from between 10 o'clock in the morning to 4 o'clock in the evening for 20 minutes. It has without sunscreen, exposed areas, and today most of us are all indoors at that time. So vitamin D really we cannot get from the sun. Cholecalciferol is available in the form of tablets, 1,000, 2,000, and 60,000 units. And in postmenopausal women, the intake of vitamin D should be in addition to sunlight exposure, and vitamin D supplementation was favorable in the reduction of hip fracture. And this is, I'm sure Dr. Prakash will know, Dr. Meeta Singh's article. She's from Hyderabad, done a lot of work on menopause, and this is from her article in the Journal of Midlife Health. When we look at pharmacotherapy for osteoporosis, I think our orthopedic surgeons will cover this in more detail. We do not use as gynecologists much of this. Only bisphosphonates is what we use, and for that. Now, mechanism of action of anti-catabolic agents are they decrease the bone remodeling and they reduce the risk of fractures, and they help to preserve the architecture of the bone. So bisphosphonates is an area where, as gynecologists, we are using it. Various bisphosphonates are there. There's zoledronic acid, which is intravenous once a year. Alendronate 70 milligrams weekly, ibandronate 150 milligram monthly, risendronate 35 milligrams weekly. And we used to use a lot of risendronate some time ago, but we realized that there's a lot of gastro-GI toxicity. They have to sit up for some time, half an hour, 45 minutes after taking the tablet. And with IV bisphosphonates, there may be fever and chills and body pain. So that is a problem. And one of the serious side, complications is osteonecrosis of the jaw. Now, but meta-analysis with alendronate with placebo has shown a 44% reduction in vertebral fracture risk, 40% reduction in hip fracture, and 17% reduction in non-vertebral fracture risk. Studies have shown very good results with alendronate, ibandronate, and risendronate also. And there's definitely a good reduction in vertebral fracture risk and in things. Now, denosumab, I'm not going to go into because I really have no experience with denosumab. So I think that I will leave that. Selective estrogen receptor modulators were popular some time ago, and raloxifene and bazidoxifene are available, and they were used because they are selective, so they have a good effect on the bone, but they don't stimulate the breast or the or the uterus. But they are very expensive, and they have to reduce fracture risk and to improve bone mass. All these medications have to be given over a long period of time, which is the downside of it, because as the time goes on, over 5 years, 7 years, 10 years, the risk of any of these hormone medications starts going up. Again, calcitonin I'm going to leave aside because this is not an agent that I'm very familiar with. Now, all I want to say is that we have hormone replacement therapy, we have things like Tibolone, and I'm just going to put it for you at the end in perspective, who should be given hormone replacement therapy. We have very clear guidelines. Those who have additional climacteric symptoms, those who have vasomotor symptoms, those who have vaginal dryness and dyspareunia with systemic symptoms, and those who are in the young perimenopausal group, those who are between the age of 50 and 60, because they are at low risk of DVT and they are at lower risk of ischemic heart and other problems. That is the window of opportunity. If we give menopausal hormone therapy at that time, for the shortest possible time, in the smallest possible dose, we will be also helping the bone, and we will be also helping them to tide over the symptoms which are very troublesome. So this window of opportunity is very, very important. And today all our guidelines show that that is the best time to give it. Menopausal hormone therapy with estrogen with or without progesterone in comparison with placebo does show a 34% reduction in the risk of vertebral fractures, hip fractures, and non-vertebral fractures. Even Tibolone shows a reduction in the risk of fractures. So these are helpful, but there are potential side effects, and venous thromboembolism, stroke, myocardial infarcts, cancer, breast, and endometrial are all the problems with that. So the challenges with current approaches with bisphosphonates, they're linked to osteonecrosis of the jaw and the GI side effects. The selective estrogen receptor modulators have all these other risks. Teriparatide can be given for no more than 2 years. HRT has increased risk of thrombosis and stroke. So finally, there are surgical things like kyphoplasty and vertebroplasty, but let's finally look at this algorithm for postmenopausal osteoporosis. And I want you to draw your attention to the first thing, that first, all postmenopausal women should be encouraged healthy lifestyle, nutritional optimization, calcium and vitamin D supplements, and we should determine their 10-year fracture risk according to country-specific guidelines. If they are in low risk, we reassess their fracture risk from time to time. If they are high or very high risk, then they may be considered for one of these agents with calcium and vitamin D as adjunctive therapy. And if they have symptoms and they are between 50 and 60, then we could consider them for hormone replacement therapy. And Endocrine Society guidelines have said very clearly, in postmenopausal women with low BMD and high risk of fractures, we suggest that calcium and vitamin D be used as an adjunct to osteoporosis therapy. In postmenopausal women at a high risk of fracture who cannot tolerate bisphosphonates, etc., daily calcium and vitamin D supplementation is the best way to prevent hip fractures. So in conclusion, I'd like to say osteoporosis is a silent disease. Peak bone mass is reached around the age of 35, decreases after that, and more rapidly in the first 5 years after menopause. Deficiency of estrogen has impact on bones as well as overall health quality of life of the woman. And calcium and vitamin D and its analogues have a positive impact on bone mineral density and will reduces fracture risk. Thank you very much for a patient hearing.
Right. Thank you, Sarita. It was very nice that you have covered the whole subject very nicely. There are few remarks I will do at the end of my, all of you. Give me about 5-10 minutes so that whatever is not covered, I'll try to cover there. Now, the next speaker is not Ameya Joshi, but speaker Dr. Prakash Kotwal from Chairman Institute of Orthopedics and Joint Replacement, PSRI, New Delhi. PSRI, I'm not sure what it is, but
this is the hospital where I work, Pushpavati Singhania Research Institute.
Okay, right. Now, he has been a professor and head of department in orthopedics in AIIMS, New Delhi. Then he obtained advanced training in traumatology in West Germany, hand and microvascular surgery in USA. He has been a visiting professor of orthopedics, BPKIH, Dharan, Nepal. This must be some hospital in or the institute in Nepal in 2001, visiting professor. The next member of Board of Studies of Jivaji University, Gwalior, Ambedkar University, Agra, Barkatullah University, Bhopal, Jamia Hamdard University, New Delhi. He has been a very busy person, ex-member, Academic Council, Pandit B.D. Sharma University of Health Sciences, Rohtak, AO Trustee 2010 to 2015, Founder Chairman, Hand Section, IOA, and President, Indian Society for Surgery of Hand, 2015 to 2017. Chairman of Faculty of AO courses in India and abroad. Then he has been a medical coordinator, National Antarctica Expedition Program, my goodness, since 1998 to 2019. So are you also in the expedition? No.
No. I've been managing it, the other issue, medical issue.
Yes. Chairman, Curriculum Committee in Orthopedics, MCI, 2007. Orations, guest lectures delivered, 8, 550 and more than 120 publications. Dr. Kotwal has authored many books and has chapters in multiple books too. He is also the editor in the editorial board of 16 journals, examiner for various universities in India, abroad, and reviewer. Guide for thesis, BSc, PhD, MS, and MD. Congratulate him. In a short life, he has achieved so much. So I ask Prakash now to do his presentation. Thank you.
Thank you very much, Dr. Ved Prakash sir, for your kind words and for the encouragement. And may I share I'm grateful to Torrent Pharma for giving me this opportunity to speak on this academic event, and also congratulate Torrent Pharma for organizing this on the occasion of World Osteoporosis Day. They have, I've been asked to talk on osteoarthritis and osteoporosis. So this is actually two big topics put together. So I'd like to give some overview about these. And I also would like to thank Dr. Bhalerao for making my job easy, because she has covered most of the things. I also say that if there are more than one speakers on a topic, then there is bound to be some repetition. And sometimes you have to bear with it, but quite often that is also important. That's why the repetition comes on certain important topics. So we talk about osteoarthritis. See, the basic thing is normally an homeostasis between the anabolism and catabolism of the cartilage. And under normal conditions, this is what happens. The chondrocytes produce the structural matrix containing the collagen, and the cartilage turnover is the result of the fine equilibrium between the catabolism and anabolic process. So the osteoarthritis is primarily a disease of the cartilage, and it is actually the interleukin-1, which is a potent pro-inflammatory cytokine, which actually synthesizes the MMPs, and which are responsible for degradation of the articular cartilage and leads to fragmentation and development of the osteoarthritis. So basically, osteoarthritis is an inflammation. They go together. Earlier, it was thought that osteoarthritis is only a degenerative problem, but well, there is an element of inflammation as well. And so the inflammation of the neighboring tissues, it causes cartilage destruction, which in turn causes inflammation again. This leads to pain and swelling and cartilage debris, which causes narrowing of the joint space, damaged bone deformation, joint discomfort, and loss of mobility that we see every day in our everyday practice in patients with osteoarthritis. So osteoarthritis of the knee is very common, as we all know, and this is basically the wear and tear of the joint. And you can see here, this is the normal picture of a smooth articular cartilage of the knee joint. And over the period of time, what happens is that the new bone formation, spurs and osteophytes form, and then the articular cartilage gets degenerated and leads to erosion and pain in the joint. The risk factors for osteoarthritis are many, the obesity being one of them, obviously. Then the age is a risk factor, and because as the age increases, the longevity has increased. So therefore, we see more and more cases of osteoarthritis of the knee. Hereditary also, because some people get it very early in their life, and they have to undergo sometimes joint replacement as early as 50, 55 years of their age, whereas some others can prolong and go on without much problem up to 80 years of age as well. Female gender, for some reason, unknown reason, is actually again very more at risk for developing osteoarthritis of the knee joint. And the pain in the knee joint is the main feature later on leading to deformity of the knee joint. So the kneeling, squatting, and muscle weakness, there are some of the predisposing factors. And then old injury to the knee joint also leads to early secondary osteoarthritis of the knee joint. Joint laxity can also cause degeneration at an early stage. And obviously the mechanical forces, and one of them is obviously, I told you, the obesity actually is a mechanical force causing early degeneration. So for the tips for management, if someone is starting to get developing early osteoarthritis, what actually he should do or not do, don't sit cross-legged, because that sometimes puts more strength on the knee joint. Don't lift heavy weights, put strain on the knee joint. They actually can lead to more pain and progress the disease. Avoid prolonged activities like standing or kneeling, gardening, or squatting for long periods. Sometimes, you know, on a Sunday morning, one gets charged that I'll go and do some work in the gardening and sit in the garden for about 2 or 3 hours and do the gardening job. And then the next day or the day later, they develop pain in the knee joint, and that becomes unmanageable at times. Avoid jerky movements of the knee joint. That also should be avoided if you want to control the pain in the knee joint. And obviously, don't smoke, because smoking has deleterious effects in many ways, in many things, as has already been said earlier as well. So what should be done actually? See, osteoarthritis, apart from the aging process, is to a certain extent is also a lifestyle problem, and therefore you need to exercise to strengthen the muscles, the thigh muscles. The workout for the thigh muscles and this thing should be really good, and that keeps the knee joint going for a longer period. Regular knee movements to avoid stiffness, immobility of the knee joint also is not desirable. Then obviously in early stages, sometimes then you can take the help of medications. Physiotherapy is a mainstay in the treatment of osteoarthritis, particularly in the early and in the moderate stage of the disease. And then later on, if the disease progresses, then you go on to joint preservation surgery, which are actually minimally invasive surgeries. And then finally, if the joint is, you go to a point of no return and the joint actually is worn out, then it needs total knee joint replacement, which has again become very common these days. There are other options like intra-articular injections, and these are all options which actually are employed before the person goes on to the final surgical procedures such as the arthroscopy or even for that matter the joint replacement surgery. And the steroids, there's one is the steroids which are injected into the joint to decrease the inflammation and pain. However, sometimes they may cause some more side effects in terms of like neuropathic joint kind of this thing, but still they may be used with caution in selective patients. The more commonly used injections are the viscous supplementation, hyaluronic acid, which is actually injected into the joint to provide lubrication, and that also helps to relieve the pain to a larger extent. The other options these days are again very commonly used are the PRP injections, the platelet-rich plasma injections, and these are actually the patient's own platelets are harvested and injected into the joint. And of course, they are also being used in many other soft tissue and other conditions, non-specific conditions. But in the osteoarthritis, they are supposed to reduce the inflammation and relieve pain. And then obviously the other thing is the stem cell therapy, which also is like becoming popular, I mean, in many other fields. So similarly for this thing also, but some of them, and the results of these are generally unpredictable or uncertain for that matter. Arthroscopy, as I said, is another joint preserving surgery which is required sometimes when the conservative methods do not help. And what does the arthroscopy do actually? It does the cleaning and removing debris from the joint and removing the toxins from the joint, then removing any free-floating pieces of bone or cartilage from the joint. So sometimes what happens is that the soft tissues structures like menisci or they get frayed, and sometimes they get caught between the bone, leading to sudden onset of pain in the knee joint, and sometimes even the osteochondral pieces, which actually act as a free-floating pieces like a mouse in the joint, and then sometimes they also cause symptoms such as swelling, locking of the knee joint, and so on. Then the arthroscopy, you try to smoothen out the rough or irregular joint surfaces such as the osteophytes and so on. And then obviously it also facilitates the limited removal of the inflamed tissue in the larger joints. So this is what our joint looks through an arthroscope. So this is the smooth articular surface of the, let's say, the femoral condyle, and that's the meniscus, which is actually also intact. Whereas in an osteoarthritic knee joint, there will be this cartilage which has been denuded, the bone is exposed, and this is the subchondral bone which has the nerve endings, and this is what causes pain. And then obviously there is synovitis, and this is because of the inflammation of the synovium. The another treatment which is also again being popularized, but of course it is still not been very much standardized, is the autologous chondrocyte implantation. So in areas in the cartilage where there are these irregular areas of this thing which expose the subchondral bone and cause pain, so they are cleared up, and then you implant the osteocyte, the autologous chondrocytes, which actually are supposed to regenerate and form the cartilage. So this is actually still kind of in the process of development. So when to opt for surgery? the surgery for joint replacement for that matter. So it depends upon the joint, which joint is actually, whether it is the knee joint or the shoulder, because all these can develop osteoarthritis. When medical management fails, when there is severe joint pain, the joint pain is such which is there at the pain at rest also. This actually becomes troublesome because the patient sometimes spends sleepless nights because of the pain at rest as well. Severe restriction of movements and severe deformity. As I had shown you in one of the earlier slides, the patient had a very severe deformity of the knee joint, making ambulation difficult. And more when all, obviously, when all other modalities of treatment fail, I have shown you some of the modalities, some of them can be tried selectively in some patients. So total knee replacement, this is what the normal knee joint looks. There is this space between the femoral and tibial condyles, and what is done, and this is actually after the arthritic knee, because now there is erosion of the articular cartilage, the gap between this thing is gone, the bones are rubbing off each other, subchondral bones, and this is causing pain, as I told you earlier. Now there is also this varus deformity developing, and this further increases the involvement of the medial joint line, and this is the knee joint after replacement of the after the total knee replacement, and this restores the normal anatomy, almost normal anatomy of the knee joint, and restores the alignment and relieves pain and increases the mobility. It actually improves the quality of life of a patient who is suffering from severe osteoarthritis. That is another example of the same type. Another area where the osteoarthritis it affects is the cervical. Dr. Prakash also mentioned in his inaugural message about the involvement of cervical spine and cervical spondylosis, and the degenerative this thing causes pain in the neck, which is also again a very common this thing, and may start after the age of 40, 45 or so, particularly in the today's this thing concept of desk workers, long hours of sitting on the computers and so on. So again, as I said, some of it is definitely lifestyle related disorder. So this is a degenerative disorder. This is also associated with muscle spasm, and one of the causes for that is mainly a postural cause, as I told you just now, long hours of sitting on the computer and the desk job and so on. And also important thing is that sometimes stress may aggravate the pain. So that also is an important underlying cause for increasing pain in the cervical spondylosis. So what should one do is to consult a doctor, an orthopedic surgeon. There are medications which can be given initially, then obviously followed by physiotherapy, neck exercises, and other modalities of physical therapy such as thermy, diathermy, interfacial therapy, or traction, and so on. And then followed by surgery if this shows definitive erosion and compression of the erosion of the end plates, vertebral end plates, and compression of the nerve roots. Then surgery, certainly it requires surgery in the form of decompression, and sometimes even in the today's context, even the degenerated cervical disc is also replaced. So there is a disc replacement surgery as well. This is an eye-opener slide, and this is actually a person. Normally the weight of the head is about 4 kg. So in this 0 degree angle at the neck, the load on the neck is just about 4 kg. But as the bending of the knee increases in these kind of positions, in these kind of actions, the load on this thing increases many-fold. So if your neck is at about angle of 45 degrees, the load on the neck is about 22 kg. And this is actually the position as shown in the picture. Is we often use it not for reading, but maybe for using mobile phone. So this is actually our day-to-day. We spend hours together on mobile phone in this particular position. So you can imagine the strain that the load that it puts on the neck and increasing the pain in cervical spondylosis. So the best way to look at the mobile is in this position where it is just about 0 degree or maybe at the most 10 degrees. The degeneration of the lower spine, the lumbar and the lumbosacral spine, causes backache. This has also been mentioned by Dr. Prakash in his opening remarks. And actually, this is the price that the man is paying in the process of evolution from this position to an upright position. So this upright position causes a lot of strain on the back, and this leads to early degenerative changes in the spine. And this is another this thing showing the load which actually the back suffers on in the various postures of our daily living. When one is sleeping comfortably, the load on the back is about 35 kgs. But as actually in the standing position, working, lifting weight in this awkward position, it is about 220 kg. So this is actually what the upright position and the various postures, not in the correct, various actions, not in the correct posture, are likely to increase the pain of the backache. So there are many causes of backache. Of course, the congenital and infections and slip disc and cancer can cause backache, but degenerative is also one of the major things. That's what we are talking about, the osteoarthritis. But the commonest cause of backache in about 70% of the patients is postural. The way that we stand, we lie down, we sit in the sofa or sleep or sit in the car or whatever, office chair or computer chair. So that wrong posture, it causes muscle spasm and increases the pain in the back. So what one should be doing is to consult a doctor, get the correct diagnosis and proper treatment, which can be in the form of just a physiotherapy, medication, or often then occasionally then you require surgery to fuse the degenerated spines or decompress the compressed nerve roots. Now we talk about osteoporosis. As has been said, osteoporosis is a silent killer. Osteoporosis is a disorder of the bones in which the bones become brittle, weak, and easily damaged or broken. A decrease in the mineralization and strength of the bones over the time causes osteoporosis. And this is what the picture looks like in osteoporosis. This is the normal trabeculae pattern of the bone and the neck of the femur. And this is what after osteoporosis it happens, that the trabeculae are destroyed and the bones become, now the trabeculae have become very sparse, and that makes the bone weak for the easy fractures. And this is the comparison of a normal vertebra and an osteoporotic vertebra. So this is again the normal vertebra. You can see the cross section, the trabecular pattern here, whereas in an osteoporotic vertebra, now you can see the trabeculae have been destroyed so much, and that makes it weak, and that leads to compression of the vertebral body, leading to compressive fractures and the deformities of the spine. So this is what osteoporosis does. So the osteoporosis affects both men and women, and more common in men, as has already been said by Dr. Bhalerao. So in women, it is about 1 in 2 women, whereas in men, it is 1 in 4. And this thing, men are more prone to sustaining osteoporotic fractures in their lifetime, has already been said as well. So normally there is a balance between the osteoblastic and osteoclastic activity, has been said earlier as well. And as we go, the osteoblastic activity decreases where the osteoclastic activity continues, and that weakens the bone, leading to fractures. And this is what happens in women after the around the menopause. There is a sudden drop in the bone mass, and this is how the osteoporosis develops. So the age-related bone loss, the bone loss increases in both men and women around 40 to 45 years of age. Bone loss is more pronounced in women because of the hormonal changes, and the bone loss is accelerated to 2 to 5% each year. And the estrogen deficiency has already been said. I would like to skip that and not repeat the same thing. India scenario is again also little alarming, because by 2015, 1 out of every 2 hip fractures would occur in Asia. So this is also obviously the future scene. And the commonly affected areas, bones affected by osteoporosis, are the wrist, the vertebrae, and the hip. And these are the areas, and this is where the bones they fracture very easily. How does the osteoporosis present? Number one, commonest is backache and generalized aches and pains in the bones all over sometimes. And the common one is the fracture of the bones. And quite often the patient presents with fracture of the bone, and then when he or she is investigated, then it is discovered that the patient is suffering from osteoporosis. This is how the fall on the outstretched hand causes the fracture of the wrist, because that's actually our tendency is that when one is falling, he tries to break the fall by putting the hand on the ground, and this is how the brunt comes onto the wrist, and the wrist or the distal radius is the most commonly fractured bone. So as had been said about the DEXA scan as well, who should have the bone density test? Women over 65 and men over 70 years of age, younger postmenopausal women and men between 50 to 70 years of with clinical risk factors, adults who have a fracture after the age of 50, because one fracture of these bones increases the incidence of refractures 2 to 4 times, many-fold, I should say. And patients with conditions who have rheumatoid arthritis or who are on medication for steroids are also likely to develop osteoporosis, and they are the ones who should be investigated for that. So the clinical challenge actually that we face is that most of the patients are often asymptomatic, and they present to the hospital or to a doctor only when the fracture occurs. And even after some fractures, people do not present there because many times, they have already sustained 2 or 3 fractures of the vertebrae before they seek medical advice. And therefore, the challenge is to identify the patient at high risk so that the first fracture can be prevented. Because as I said, a single fracture increases the risk of refractures many-fold. This has also been covered very nicely by Dr. Bhalerao. So osteoporosis again is a silent disease. Bones do not complain until they break, and therefore treat osteoporosis and do consult a doctor. The management is non-pharmacological, pharmacological. This has also been covered quite a bit, and there are newer drugs coming up. The commonly used drugs are the bisphosphonates, teriparatide, and denosumab. And with some plus and minus this thing for both of them, and then obviously you have the surgical treatment for selective patients. In short, the various pharmacological agents, they are actually can be categorized into 3 categories. The ones which reduce the bone resorption, for example, bisphosphonates, denosumab, and disam. Whereas there are drugs which increase the bone formation, particularly the teriparatide, which is again very commonly used. This can also be used in a fracture and will not interfere with the healing of the fracture. Whereas the disadvantage with bisphosphonates is that, of course, this has been a controversial subject, but still it is being reported that the use of bisphosphonates during the healing of a fracture can delay the healing of the fracture, and they should be used with caution. And then there are ones which cause both. They reduce the bone resorption and increase the bone formation, but then they are not being used because of their toxicity. The vertebral fractures, again, are said very common, and there are now that actually vertebra gets compressed and causes the wedging of the vertebra. So this can be restored. The height can be restored by ways of vertebroplasty, where you insert the bone cement into this, or there is a kyphoplasty, where actually you insert a balloon, and then in the balloon you insert the PMMA. So this is actually better because the extravasation of the cement, this thing is not actually to cause problems to the neural tissue. So the risk fractures can be treated by surgery or by plaster, as shown in this, and this can restore the normal anatomy of the bone. The hip fractures, this is the fracture to the neck of the femur, and this can be treated by this kind of fixation. These are various fixation by a half replacement, where it is only the replacement of the femoral component, or a total hip replacement where both the acetabular as well as the femoral components are replaced. Osteoporosis causes the vertebral compressions, and as the number of vertebral compressions increase, this is what leads to the kyphotic deformity of the spine, particularly in the more common in the elderly ladies. So what should we do to prevent osteoporosis? Number one, good nutritious diet, a good level of physical activity, a loading activity which causes load on the bones, minimum of about 40 minutes daily, at least 4 days in a week. Calcium and vitamin D supplementation, a lot has been said about this. Even the next speaker is likely to again dwell upon this in detail. And sitting in the soft sun in the morning, and obviously smoking and alcohol goes against it. The calcium has also been said. I'll skip that because even I think there will be a next lecture. We'll be talking about this in detail. So osteoporosis actually is kind of, it's not a disease actually. It's an aging kind of thing. You know, it's like you cannot stop graying of hair as age grows, and you know the osteoporosis is bound to come. But then one must learn to live with osteoporosis. So don't let this interfere with your life. You know, one shouldn't get depressed that, you know, I got osteoporosis and go into a shell. Being active, on the contrary, improves the bone strength. The more active you are, as I told you, the loading exercises is going to improve the osteoporosis, and immobility will have the adverse effect. Bone health will worsen, as I said, if you are immobilized. Go out and enjoy leisure activities and use railings, cane or walker for stability, so avoid fall. And this is what Dr. Prakash also mentioned for the fall mechanism and to prevent fall. This is very important because that actually, as the DEXA scan report says, even the patient can read it, that, you know, increased risk of fracture. So that actually causes disturbance in his psyche, that, you know, what if I fall? So now, you know, this is, there's some advice so that to reduce the fall. And this is what happens in the young age, we tend to fall more forward, whereas in the elder age, the center of gravity gets disturbed and the fall is on the back side. Even people have advised use of hip protectors, this thing, but somehow they are not been very, to prevent the fracture of the neck of femur, which is very common, but not been very popular about this. So some very simple things I would like to say about how to prevent fall, because fall prevention is again a very important thing. You know, in your house, you should minimize the clutter, and the carpet must be smooth. It should be well anchored to the floor. The minimum furniture should be in the custom plate. It should not be littered all over. And even if you have used it for some place, you clean it up immediately. The mats in the kitchen, bathroom, or this thing should be non-skid or anti-skid tile should be used. It is very important. Another thing, most of the falls occur in the washroom, in the bathroom, because either it is wet, the floor is wet, or the patients wake up, person go into the bathroom. At that age, we are under the medication for various other things, hypertension, blood pressure, heart or something. Sometimes that also causes little dizziness, postural hypotension, and patient has a fall in the bathroom. So the non-skid bath mats, as I said, must have these kind of bars to hold or to break the fall in the bathrooms. Another thing is the staircase. The staircase must be very well lit, light switches within reach, and there must be a light switch at the top and the bottom of the staircase. Switch on the light even if you get up in the middle of the night. If you're sleeping with your partner in the bedroom, and if you had to go to the washroom in the middle of the night, you generally tend to not to switch on the light because it will disturb the sleep of your partner, and you kind of walk to the washroom, and this is where sometimes some people stumble and fall. So it is always better to use some kind of a light or this thing and use the railings. So how to maintain the balance of your body? This is also important. Keep your hands free. Use this kind of bag rather than holding briefcases. The another important thing is that, you know, when you walk with your wide base and swing your arms so that, you know, the center of gravity is in the center and you do not tend to fall. And if you have to turn, don't just turn around that, but take a U-turn so that you don't get dizzy, particularly for the elderly in the elderly age group. So when it comes to bone joint health, prevention is better than cure. Exercise daily, maintain body weight, use your joints, do not abuse them, healthy lifestyle, and take these supplements. So in the end, I would like to say, I can't stop getting old, but certainly I can work to prevent osteoporosis, injury, healing, sweating, obesity, and control the medical conditions which generally sometimes people develop at that age, like diabetes, thyroid problem, and improve the home environment, as I said, and recognize symptoms early and seek early intervention. Thank you very much for your kind attention.
We have got one more speaker, Dr. Amey Joshi. We'll do the question answers if time permits. So I would advise you to put up the curriculum vitae of Dr. Amey Joshi. I will, yeah. Dr. Amey Joshi, MBBS MD, endocrinology, you're welcome. And I'm reading your biodata. He's a consultant endocrinologist, diabetes and endocrine clinics, Borivali and Vianda. Consultant endocrinologist at Bhakti Vedanta Hospital and Research Institute. Then he is in Bombay, Mira Road, and investigator at many clinical trials. Many clinical trials he has done. Multiple publications in national and international journals, special training in advanced diabetes, University of Leuven, Belgium, thyroid ultrasound, Tata Memorial Hospital, Mumbai. He is a pediatric endocrinology training, Indian Society for Pediatric and Adolescent Endocrinology. Member Endocrine Society of USA, member Indian Society of Bone and Mineral Research, and associate member of Indian Society of Pediatrics and Adolescent Endocrinology. He's a busy person. I welcome Dr. Amey Joshi to present his talk on osteoporosis, whatever he is going to present. Thank you. Dr. Amey Joshi, for you, please.
Yes, sir. If I can be given permission to share the screen.
Yes, sure.
Thank you. At the outset, I would like to thank Dr. Prakash sir for the nice introduction, as well as Torrent Pharma. I would also urge everyone who is listening to consider becoming member of Indian Society of Bone Mineral Research, which is a dedicated society across specialties dealing with osteoporosis and bone health. I understand that it's already 9 o'clock, and I'll keep my talk to approximately 15 minutes, focusing only on clinical and practical messages. If there are any theoretical questions, we can always discuss them in the end. I'll start my talk with a simple case of a 58-year-old lady. She has came to your OPD, simple weakness and backache. You see many patients like this, some heartburn, she's tired, obese. You don't find anything in the examination as such, and do some investigations thinking that maybe I'll get something out of the metabolic panel. You find that the TSH is slightly high, the vitamin D is low, she has got an impaired glucose tolerance, slight abnormal lipids. A typical patient, 8 out of 10 times when you investigate, this kind of pattern comes, and you end up starting small dose of thyroxine, telling her that, okay, we will assess you later, do your antibodies and all. and you find out that she has got vitamin D deficiency. So attributed everything to vitamin D deficiency and obesity. She's advised about lifestyle modification. She's treated for subclinical hypothyroidism and given treatment for vitamin D deficiency along with calcium. Just look at the treatment. She was given vitamin D. I'll come to it which vitamin D was given. Advised calcium and thyroxine. Now you have treated her correctly, but 3 weeks later she has landed up in an emergency department of the hospital. She's cursing the doctor who had previously treated her, and I went and go and see her. She has abdominal pain. She's quite incoherent. So I asked, which medicines are you taking? What is going on? What is going on, and what is going not? And we try to do some basic investigation, and we find out that her calcium level is 13.2. So a lady who was having aches and pains, body ache, she's given calcium vitamin D, and the calcium level has gone up to 13.2. She has got renal failure, and her PTH level is low, and she has landed up with vitamin D toxicity. She's treated, but what I want to emphasize is try to look carefully at the prescription. There is decadurabolin, there is arachidol that is given intramuscularly every week. Then there is uprise D3 or calcitriol also that is given. And then there is a calcium powder, then calcium tablet, and then she's asked to go in the sunlight. I mean, and the diagnosis is severe osteoporosis without doing a bone density. What I want to emphasize is, I'm not saying that it is wrong. We also thought that COVID pandemic will last for 2 months, and everybody started taking weekly vitamin D, and now it's 6 months, and I see patients who come with borderline hypercalcemia who have been taking vitamin D for weeks together. So 6 months they have been taking weekly vitamin D. What I want to emphasize is, remember that vitamin D is not a super vitamin. It also has a dosing. It needs to be given in a measured manner along with precautions. Secondly, always remember that when you tell a vitamin D ka test kar lo, it is always better that you specify which vitamin D is to be done. There is a 25 hydroxy vitamin D which is cheaper. There is 125 hydroxy vitamin D which is costlier, but it is relevant only in patients with kidney disease, in patients who have got end organ failures or on anticonvulsants. What is important for you is a cheaper 25 hydroxy vitamin D, which is a storage form of vitamin D. And then there are consultants whose prescriptions I have seen, and they have been giving calcitriol. Ye active wala vitamin D hai, so you start taking this. I must tell you that your active vitamin D, the body has no control absolutely. The moment you pump in 2-3 tablets of calcitriol and then, oh, I'm feeling better, then you keep on increasing to take 2 tablets a day or 3 tablets a day, and suddenly you find that the calcium levels have shot up. The patient is having features of hypercalcemia. I showed you the case. The beauty of giving 25 hydroxy vitamin D or cholecalciferol, the powders or sachets, or the Shelcal XT tablets or kind of tablets that you give, is that there is at least some regulation in the body which prevents conversion of 25 to 125. Only when that regulation is overwhelmed do the people have hypercalcemia. But when you give calcitriol, there is no regulation of the body. Patient can mount hypercalcemic response. So be careful when you order vitamin D, insist on 25 hydroxy vitamin. When you give, preferably give calcirol, cholecalciferol, and do not give calcitriol. Remember the normal levels 30 to 100, insufficiency is 20 to 30, and deficiency is less than 20. You can always remember this. And I have put in this slide because at least for the pediatricians, when you are treating, the simple principle of 60,000 unit given for 6 weeks or 8 weeks doesn't work. I have also seen a neonate given 60,000 unit 6 weeks and coming with hypercalcemia. So always remember the age of the patient you are treating, the weight of the patient you are treating, because overweight patients need higher doses of vitamin D, and any other comorbidities the patient has. And this is again what madam has also shown, the desired calcium and vitamin D intakes and the upper levels that can be given in the day. When you try to correct daily dosing for deficiency, it is 2000 units. And if the person is more than 18 years of age, you can give up to 6000 units per day. If you want to correct the deficiency slowly, daily dosing is okay. So the summary what I want to tell you is that do not blanketly write vitamin D for everyone. Weekly prescriptions are those who are deficient. Monthly prescriptions are for those who want to maintain sufficiency. And when you are treating deficiency, always look at the weight of the patient. You may not remember the age, but if the weight of the patient is more than say 80 or 90 kilos, don't stop at giving 8 weeks of cholecalciferol. You must give it till 12 weeks. And if the weight is beyond 100 kg, try to give weekly for 16 weeks. But if you are dealing with somebody who is 30 kg, 35 kg, not right to give blanket 8 weeks. You should tone down to 4 to 6 weeks. Maybe consider measuring vitamin D and treat it accordingly. As previous speaker said, if you want to take sunlight, you are welcome, but you have to go in the afternoon sun. UV lamps, we are using it for OPD sterilization, but they are a good source of vitamin D and skin cancer both. And obviously food fortification, which is in fashion. There are a lot of people who come and tell a doctor that vitamin D you had given. I work in Bhaktivedanta Hospital. I am a vegetarian, and they come with that red dot. That doctor, that tablet has a red dot, or the solution that you have given is having a red dot. And so I did some research to find out where this red dot comes from, and actually it is the sheep's wool that is the commonest source of vitamin D. So after you convince the patient correctly, they will be willing to take that sheep wool derived vitamin D. And if they still insist on a green dot, there are preparations which are made from mushroom and oysters, and yeah, you can use that. This I told you that calcitriol is not better than cholecalciferol. It is cholecalciferol that is the needed form, except exceptions. Now, this was a very interesting study, and I would like you to pause and see the lines of. This was done at Nair Hospital when I was an assistant professor there, and we decided to give 30 patients different dosings of vitamin D, 30 patients in each arm. So the line that shot up is the oral 6 lakh unit of vitamin D. So when the patient was given oral 6 lakh unit of vitamin D, the levels shot up from 10 to 90. And some people, even with single arachidol, mounted hypercalcemia, not hypercalcemia, but hypervitaminosis, doses above 100, vitamin D levels above 100. And then it rose fast, came down also fast. The single intramuscular, which is represented by a dark red line, is a beautiful rise in vitamin D that is achieved by giving a single intramuscular arachidol. If you give single intramuscular arachidol, the line rises, you achieve a sufficiency by a week, and it's maintained for 12 weeks. Now, what happens when you give a weekly dosing? It mimics exactly the intramuscular preparation, and you get a good response. And if you give daily 2000 units, that also works well, but is slightly less better than intramuscular single shot. So when you give arachidol, never give 3 doses. 1 dose is sufficient. Oral 6 lakh unit is not the best treatment. Do not give an injectable preparation orally. You don't need 3 doses of 6 lakh unit, and you do need to maintain vitamin D levels by whenever you give a first correction, you need to maintain by giving some therapy. And so comes the realities. The realities are oral 6 lakh unit is in fact capable of causing toxicity. Single intramuscular is sufficient, and maintenance therapy is needed. It is a myth that all commercially available vitamin D preparations are safe and effective. And this was a paper that was published by Rajesh Khadgawat, in Indian Journal of Endocrinology. They sent a lot of vitamin D preparations purchased from the market to a drug controller for analysis. And you will be surprised that a 60,000 unit can contain 99,000 unit also, and can contain 16,000 unit also. So 70% less to 70% more vitamin D is available in the preparations that we are using. Choose your choice of preparation carefully. There is a lot of disparity in the market. Government is not willing to accept that generics have problems. But when you want to preserve your integrity and want that your pen should give the best result, choose the best preparation. It is thought that if I give more vitamin D, the bones will build stronger. Always remember that you don't need excess vitamin D. You need optimum vitamin D. Vitamin D toxicity is a state where bones are lysed or the calcium is pumped out of bone. So always be measured in giving vitamin D. Now, in last 5 minutes, we'll be covering about calcium. And people always ask that only taking vitamin D, is it sufficient? And most of the times, if you are conscious in having a good dietary intake, at least in females, if it is not a postmenopausal female, most of the other populations, they must have a good vitamin D. Vitamin D must be supplemented. But calcium, they can have a measured intake and suffice from the diet also. This is just for a theoretical purpose. Nobody is going to remember this properly, but whenever you want to look at the calcium levels in common foods, you can refer to these slides. And if you want my PPT, I can definitely mail you. There are a lot of fancy preparations in the market, and people marketing that you take a orotate preparation, you take this preparation. In fact, calcium carbonate is the best preparation. It is the most economical preparation. It's available in all public hospitals also. The only problem is gastric acidity is essential, and so people are antacids. Calcium carbonate may not be well absorbed. It is otherwise a best preparation. The costly preparation should be used only when there is a rare condition like achlorhydria. There is a specific indication for citrated calcium preparation. The CCM is when the patient has kidney stones, because citrated calcium preparations can chelate the stones and can be better taken by people on kidney stones. And yes, they can be taken empty stomach. Now, when you are giving more than 500 milligram of calcium, don't take 2 calcium tablets at one time. You divide the calcium in 2 parts for better absorption. And remember that lactate and gluconate calcium preparations, if somebody is marketing, just throw them out. If somebody is marketing coral calcium, just throw it out, because coral calcium is not a superior preparation. It's just a costly preparation that can be contaminated with lead because of the source of manufacturing. So it is better to stick to calcium carbonate and rarely calcium citrate. Now, how to identify whether the calcium tablet is good? Just take the calcium tablet and put it in a glass of water or a lime juice. It completely dissolves in half an hour. Now, many of our patients do not tolerate calcium. Just tell them that make a glass of lime juice, put your calcium tablet in that, and it will dissolve in half an hour. Drink that lime water, and you will always tolerate that kind of calcium intake very well. So calcium and vitamin D supplementation is important. It is necessary. But one thing I want to emphasize, today is World Osteoporosis Day. If a patient has not confirmed osteoporosis, do not give only calcium and vitamin D. It's important, it's essential, but it is not the treatment of osteoporosis. Osteoporosis is a disease. There is a treatment available for it. In fact, multiple treatments. And consider referral to an appropriate specialist if somebody has got osteoporosis. There is a myth, and earlier my cardiology friends used to first knock off the calcium that I wrote, and I have to convince them that at least till 1 gram of calcium, it can be safely given. Whenever you are giving calcium, at least when a patient asks you, the doctor, you are giving me calcium, are you monitoring anything for safety? Tell the patient that if you are keen on, and I will definitely want to monitor the safety, and that I will do by doing your urinary calcium creatinine spot sample. If I am maintaining it between 0.1 to 0.25, I can assure you that your kidney stone is not because of the calcium preparation. You are being safely treated, and you are in safe hands. There is a notion, patients with calcium of 7 or 8 sometimes low calcium levels say that, doctor, I had kidney stone, so please don't give me calcium. The reality is that if you are giving calcium in a monitored manner, it is not associated with risk of increased kidney stones. There are multiple other factors, and it's a separate topic altogether. But if the patient asks such question, you tell him that I will monitor your urinary calcium creatinine, and I will prefer that you take a preparation which helps in treating kidney stones, that calcium citrate. Now, let us try to look at, and many people will say that, okay, vitamin D is everybody's medicine. Fertility, it improves. PCOD, it improves. Cardiac ailments, it improves. But you must remember that there is no hard randomized control trial evidence to help in all these. What it improves is essentially musculoskeletal health. It is not the cure of obesity. Your weight is not going to come down by taking vitamin D. Your cardiac element is not going to go. Also, PCOD is not going to disappear, nor are you going to conceive after taking vitamin D. But your bones and muscles will definitely become stronger. It will definitely prevent falls. And it is the primary treatment of improving musculoskeletal stability. The same patient, now we have learned about calcium and vitamin D. I will just share one case to sensitize you which one investigation you should do if the patient has less money and you want to prescribe vitamin D. Because many times we prescribe vitamin D without doing vitamin D levels. And then we are in a dilemma that should I do a test worth 2000 or 1500 rupees? I think it may not be done. Your clinical acumen suffices, but you must do one test, and that will understand from this situation. The same patient that we saw the first 10 minutes ago, the same 58-year-old lady, she is diagnosed with vitamin D deficiency. You have treated vitamin D deficiency, and this time you have been very careful in treating. You gave her cholecalciferol 60,000 unit once a week for 8 weeks, absolutely textbook treatment, and still she is bad. And still she is in a situation which is not very good, and her calcium levels have increased. That means her baseline calcium was high. Your vitamin D treatment was not wrong. The baseline calcium of the patient was high. What went wrong is that she had a condition called as primary hyperparathyroidism. It is seen in 1 in 1,000 population after 4th decade of life, not an uncommon situation. So whenever you find that patient is not improving after giving vitamin D, do a calcium level. And I will suggest, if you are prescribing vitamin D to a poor patient, a charitable lab will do calcium report in 20 rupees or 50 rupees. At least get a calcium level done. And this is a quick recap. I end my talk. I have been a bit fast because I thought that probably we have exceeded the time, but tried to convey only take-home messages. And this is it. Vitamin D is a hormone. If you find that your patient is not improving on vitamin D and you suspect that there is a problem, refer to an endocrinologist. It has salutary effects on the musculoskeletal system. It has extraskeletal effects, no doubt about it, but they are supportive. We need to follow the correct prescription. Like you are measured in giving thyroid tablet, measured in giving diabetes medicines, be measured in giving vitamin D. Therapeutic pattern has shifted towards small oral doses rather than a 3 injection le lo and then be happy. Pattern is no longer there. Correct initial diagnosis is the most important. And if your vitamin D has not worked, it is always better to assess calcium, or it is a very good practice to check calcium level before you prescribe vitamin D, even if the patient cannot afford vitamin D. And then in conclusion, I have put up some simple measures. None of these are very expensive. They can be afforded by all, and they will actually prevent falls if done regularly. I'm not saying that your bisphosphonates, teriparatide, denosumab will not work. They are excellent medications, but they will only work when your basics are right. And correct your basics, that has to be in your prescription before you prescribe any further treatment for vitamin D deficiency or osteoporosis. I again thank all of you from the bottom of my heart for patiently listening to my talk of the day. And I thank Torrent Pharma and Dr. Ved Prakash sir for giving me this opportunity. Thank you again.
You've done great, Amaya. Whatever deficiencies were there in the treatment modalities and misunderstanding about calcium, vitamin D treatment, you have removed. Calcitriol should not be prescribed as a routine. It should be only given to people with nephrotoxicity or people who are with failing kidneys, with renal failure. And you are also, by giving normally this, you are preventing your kidney to not do its work in converting vitamin D to calcium. And it has got to be the effect lasts only for 12 hours. If you want to have 24 hours effect, you have got to do second tablet. And hypercalcium has done very well. Thank you.
Thank you, sir.
Now, friends, I think the next item was, but not now, was a yoga expert giving you instructions to change your lifestyle, but that was not to be. He got bored and then he left. So I think our deliberations went a little more than they should, but it doesn't matter. We have learned a lot in this session. I'm very grateful to Torrent for this. I've got some more remarks to make, but if time permits, if everybody wants it, then I will give my experience about all the lifestyle diseases and about osteoporosis also. So I would ask now the audience to send their questions to particular people, which
I think they've put their questions, sir, in the chat box. I can see the questions.
Chat box. It's here.
Yeah, can I read it for you, sir?
Yes,
Can I read
please.
it for you?
Yes, please do.
Here there is a comment. Sir, my mother had early menopause at 40s and single kidney since birth. Any extra care of any restrictions with respect to oral calcium and vitamin D supplementation? Any risk of renal stones? It is from Dr. Sudhakar. It is from Dr. Sudhakar.
Acha, Sudhakar from?
I think it is from Hyderabad.
Acha, Dr. Sudhakar. Please, who will take this question? Amaya?
Yes, sir. See, I think if her renal function of a single kidney is normal, she is ideally, if you rule out contraindications like hypertension and dyslipidemia, candidate for HRT for in a guarded manner at least for a decade. Definitely, you must consider giving her calcium and vitamin D. Maintain her vitamin D normal and at least give 500 milligram oral calcium as supplement. You may consider doing her baseline BMD and then monitoring it every 2 to 3 years. And then, I mean, just look at other comorbidities like autoimmune hypothyroidism and hypocalcemia are common in early menopause. So just screen for them. I would also like to invite comments from both other speakers. I think Dr. Bhalerao is a gynecologist and she can enlighten on the gynec perspective of it, and Dr. Kotwal too.
Yeah, I think, early menopause, premature menopause, there's definitely an indication for hormone replacement in this patient until the natural age of menopause, and that will help her definitely. So I agree with Dr. Amaya completely. Oral calcium, vitamin D supplementation, and MHT or menopausal hormone therapy.
How long will you give?
So in premature menopause, we recommend hormone replacement till the natural age of menopause, which is about 50. So we at least till 45 or 47, they should take it.
But they say that you should not give it more than a couple of years.
But at this age group, this is the window of opportunity where the risks are lower and which will benefit them for a longer time. So this is actually the between 40 and 60 is a much safer area as compared to 60 plus.
Thank you. Anyone else who is likely to ask questions?
Yeah, there is one more question, sir.
Bolo.
What raised N-terminal tetrapeptide in 36 years male indicate in otherwise normal biochemical parameters? It is Dr. Prakash Shivram Care from Mumbai.
Yeah, I think I'll take this because
Yes, okay. Because I couldn't
okay.
listen carefully. Yes,
See, first of all, you should understand the context in which urinary NTX is done, because these markers have not yet been standardized for Indian population. We don't have a population normatives for urinary NTX. Now, if it has been done because of some reason, then you should try to rule out certain conditions like which pertaining to workup for secondary osteoporosis or secondary bone resorption, which are most commonly hypogonadism. So testosterone deficiency needs to be ruled out, hyperthyroidism, hyperparathyroidism, celiac autoimmunity, and myeloma. At least an attempt should be done to rule out. Other than, I mean, I presume that biochemical parameters are normal. That means calcium metabolism and vitamin D levels are normal. So I'll suggest further workup to rule out these 5 parameters.
Thank you. Okay. Anything else, personality?
Yeah, there is one more question, sir. Different calcium preparations are absorbed in different way.
Yes.
Which preparations are better? CCM, orotate, or calcium carbonate?
Now, I think Amaya is the right person. Who will be taking it?
I already answered this. I think calcium carbonate is what we prefer. CCM only in situations where there are kidney stones or achlorhydria. I'd also like to invite orthopedicians come in, Dr. Kotwal, sir, if you can also let us know your preference.
Yes,
Dr. Kotwal. Yes.
Yeah, actually, well, I agree that calcium carbonate is the most commonly used this thing. However, there are also some reports which say that calcium citrate has actually certain advantages over calcium carbonate. Number one, that it has no relationship with food. You know, the food doesn't delay the absorption of the calcium. That's number one. And the second thing is that, again, like what Dr. Amaya said, you know, the kidney stone formation is reportedly less with the use of calcium citrate. But otherwise, calcium carbonate is also kind of a good calcium salt.
Yes. My experience also shows that Hyderabad has got a lot of kidney stones, and people are always worried about taking it. So it's better to give calcium which absorbs better. Calcium carbonates absorbs around 33%, and citrate malate absorbs around 55 to 60%. So maybe that use of these two molecules is good. Orotate, you've got to give big doses. I don't know how much it works really. Okay, thank you. Anything else?
Yeah, there is one more question, sir.
Right, okay.
At what interval we should do urine calcium and creatine?
For?
Nothing is mentioned, but he has just mentioned what interval we should do urine calcium and creatine.
That was a part of my talk only, that
Yeah.
whenever you are giving calcium supplementation and worried about kidney stones, you should do a urine calcium creatinine level. You can do it 4 weeks after you start your calcium supplementation to know that whether there is increased calcium excretion in the urine. However, if the patient says that he or she has got a past kidney stone, it's a good practice to do a baseline urine calcium creatinine, because sometimes patients can be hypersecretors. I mean, this is something digressing, but yeah, when you are treating with calcium preparation, as a safety monitoring at 4 weeks, you can do urine calcium creatinine. It is not a 24-hour sample, it's a morning spot sample. And if it is normal, you can safely convince the patient that you are not doing any harm.
Good.
Thank you, Amay sir. Maruti, do you have any questions? Some more?
No.
Now, Do I have a few minutes or are you all bored of a long meeting?
Go ahead, sir.
Yes, good. So I would take up a few things which is according to my long experience in lifestyle disorders. While I respect Dr. Kotwal's treatment of osteoarthritis, my experience has shown that adoption of the Western lifestyle is the main cause of not tolerating osteoarthritis pain. Stretching of joints to the full level is highly important. So yoga, sitting, squatting, Indian style, not cross-leg actually, but the Vajrasana or sitting on the knees gives complete lubrication of the joint, and you should continue that habit of being, and that has led my knees to be normal up to my age, which is now 88. So I have no knee pains. Used to have in between. When I started doing this, it went away. And I have patients for a long time on chondroprotective medicines, which I feel MSM, collagen, these things are really good for many patients. And calcium, I have seen people treating osteoarthritis with osteoporosis knees for a long time before they came to me. And you treat osteoporosis and they get better. So movements, asana, pranayam, good sleep. Obesity is not mentioned in this. That is also a very important cause. But obese people don't have osteoporosis, but they certainly have osteoarthritis and other problems like back pain, cervical pain. Now, one more thing which I have noticed, which all of you should know while treating as clinicians. I have got patients with such big folders who have come for headache and giddiness. They have gone to neurosurgeons, they do the brain scan, and hardly any scan of the cervical spine. So the neurosurgeon says nothing wrong, go, and give some painkillers and disappears. For the giddiness, they give Dizerong, something which they need to give for giddiness. Then they go to, for the chest pain, they go to the cardiologist. For the back pain, they go to, their own doctors who prescribe some medicines. And nobody really thinks that from head to the tip of the fingers, from the chest down to the lower back, all symptoms is only one disease, and that is cervical disc disease. So must be very careful when patient complains of pain in the scapular region, shoulder. You must always, and the giddiness and headache, you must always think of cervical spondylosis. Be aware. And nowadays with IT technology, it is increasing. And for osteoarthritis, squatting is a very good exercise. Don't discourage. When people come to me with knee pains, the first thing I ask whether they can squat. Say there is difficulty. Don't stop them. I will give you medicines to relieve, give them chondroprotective drugs and some painkillers. And after about 5-6 months, they said their pain is gone. So it is highly important. Then one more thing I wanted to say to Prakash, that when there is a single joint involvement in osteoarthritis, uni joint replacement is highly recommended, or correcting the alignment by high tibial osteotomy in young people is still very much, and I do practice even now, very simple methods of doing it.
Sure.
Then DEXA scan is not available everywhere, and the affordability is not there for many people. And so it is difficult whether everybody will go regularly for they will do it once, they think it is a treatment. Then second, even if you prescribe, they won't go. patients are well known for not taking proper doses of medicine also, and discontinuing treatment the moment the relief takes place. So you must tell them that whatever we are prescribing, it is a lifestyle disorder and lasts for your whole life. So it is highly important. These few remarks I wanted to say. Then question of money availability for prescribing medicines in various lifestyle diseases. So most of them ignorant from rural area. So that way, I think you should be very careful. I'm very glad that Ameya has talked about all the problems of prescribing Aracatol injections. Only one single injection, yes, you can do. But otherwise, weekly 5 or 6 doses are good. And when you investigate in osteoporosis, you must include parathyroid hormone also in the beginning. Serum calcium, serum phosphorus, and these things are highly important, even parathyroid hormone assessment. Now, for kidney stones, I think you must drink plenty of water. This is very important to stress, and most of us don't drink. And most of them sit in, he has also mentioned very nice, I congratulate for him for the digital distraction, which is the greatest source of misery in present world. Bending down in front of the monitor, slumping in the chair, not getting up for hours and hours, and not walking out, no doing exercises. The yoga exercises, highly important. You stretch all your joints and you will remain well whole life, I can tell you, with healthy nutritional diet. You don't have to take non-veg too much, but yes, calcium containing fruits, vegetables, milk products, other can be taken. You don't have to do anything about that. And last, low back pain is a lifestyle problem. And if you start doing exercises from the beginning, you can withstand all the problems which your life presents to you in your lifestyle. Thank you so much for listening to me for a few minutes. All the best.
Yeah. Sir, before I conclude this session,
yes,
I would like to thank all the speakers, the wonderful speakers, for this illustrative discussion, sir. And thank you all for joining us today on World Osteoporosis Day on this session on Shelcal Bone and Joint Care, e-conclave. The session recording would be available. We shall be circulating the link post the webinar to all attendees.
Great.
Yeah, and Shelcal feels immense gratitude to you, especially Dr. P. Kotwal sir, and Dr. Sarita Balarao madam, and Dr. Amay Joshi for joining us. And also a big thank to Dr. Prakash being a moderator for this session, without whom this session won't have been possible, sir. Because you have given a good...
Don't say that. Don't say that.
And it has been such an honor to us. So Shelcal celebrates October as Bone and Joint Healthcare Month. So let the knowledge caravan continue. We continue to strengthen India's stand against bone and joint disorders.
Yes.
Thanks a lot, sir, and good night to all of you, sir.
Thank you for getting us all together for a lively evening. Thank all the speakers who have done so well. Thank you.
Thank you, Prakash sir. Thank you, Amay Joshi sir. Thank you, Sarita Balara madam.
Thank you, Dr. Prakash sir. Thank you, Dr. Kotwal, and thank you, madam.
So much, sir.
And thank you, team.
Good night. Thank you. Good night. All the best.
Good night. Thanks a lot.
Madam, thank you so much.
Pleasure.